Okay, let's start. So, hello, everybody, wherever you are around the world. Let me say some introductory words concerning this new series of young researchers webinars. This originated from an idea which Elia Fisher, he will talk to you in a minute, came up with and is part of our WFNR strategy initiative to involve young scientists, young clinicians, much more than we did before. That, of course, is also aimed to increase and facilitate all enthusiasm into the field of neurorehabilitation, especially also among young clinicians and young scientists. So the idea of this new series of webinars, which at the beginning will be quarterly, so every 3 months or so, on the first Wednesday in the month, the idea is to provide a platform for young researchers to communicate their results with peer groups as well as with more experienced people if they are available. So opening up a channel for sort of better interchange. In addition, WFNR is planning, and we are at the moment in very much on the phase to put all the necessary elements together to start a decent mentor-mentee program, allowing over the WFNR website mentees to find mentors for particular areas of research or other academic activities. Professor Wayne Fang has done a lot of work on this, and he's very experienced also with mentoring programs at Duke. And he will say some words in a couple of minutes about the structure of the WFNR mentor-mentee matching program and how this will work. But before we start, let me express my gratitude, first of all, to Christian Andreescu and his group in Romania, who is always very diligently helping us technologically to bring these webinar series forward, and also to Elia Fisher, who is in some sense the father of this new series of webinars, and probably Elia is going to say some words. And after that, Professor Wayne Fang will introduce you shortly into the mentor-mentee program we are envisaging at the moment. I hope it will work pretty soon, within the next 6 or 8 weeks, that it will become available. And after that, we will have the delicate pleasure to have our 2 young speakers presenting their work. So Elia, you want to go on? Thanks.
Okay, sure. Thank you so much, Volker, for the nice introduction. I also want to give a warm welcome to everybody. So not only the people invited, the speakers, and of course the experts, but also the audience attended. Also, many thanks in advance also to Christian, who provides us with excellent technical support. So Volker has basically covered the most important points of the ideas behind these quarterly Young WFNR research webinars, which have been established by me, Elia Fisher, the chair of the Young WFNR. Volker, as I said, has already covered the most important points of the idea behind these webinars and of the mission behind the Young WFNR as such. So the mission of the Young WFNR is based on 2 pillars. It's first to connect early career professionals in neurorehabilitation to foster the exchange around the world, to build sustainable, long-lasting connections for development in clinical collaborations and also research collaborations. The second pillar is to promote research and education in these early career professionals in neurorehabilitation. So really to convey also the skills and the knowledge in order to secure the future of neurorehabilitation. Where does this webinar series come in? Of course, it aims to connect the early career professionals. So as Volker said nicely, the speakers will have the excellent opportunity to present their work, to get exposure, and also to get valuable feedback to their presentation and to their research, maybe also new inputs, new insights. For the audience, it will be also an added value, of course. It may inspire them also to pursue research of their own, and it's also educational. So let me give you a quick overview about the program of today's webinar. So first we have the word of welcome, then last minute change. We will first have the presentation on the WFNR mentorship program, also a very highly essential program for young early career professionals. Which we'll hear about later by our special guest, Professor Wayne Feng from the Duke University in the United States. And then we have our two speakers who have prepared a very interesting talk for you, which we will be able to discuss afterwards as well. Maria Spier-Brunel from Colombia and my colleague Nadine Patt from Switzerland. I will introduce them shortly later on. To the experts, so I've given also the speakers the chance to have experts invited who will specifically comment on their presentation, to give additional feedback also from a more senior, more experienced member. Of course, everyone is very much invited to give feedback and to ask questions. First, as the first expert, we have Professor Caterina Pisterini, who is the director of the ICS in Margheri, Pavia in Italy. She's also the general secretary of the WFNR and has tremendous research experience in various domains of neurorehabilitation. Has also supervised our first speaker, Maria Spier-Brunel, in her internship in Italy. So those two know each other well, and she will certainly be able to ask a lot of important and vital questions and give additional input. Then we come to the second invited expert. It's my pleasure to welcome Dr. Abhishek Srivastava, who's the director of the Center for Physical Medicine in a hospital in Mumbai. He is also the chair of the WFNR Multiple Sclerosis and Demyelinating Disorders Special Interest Group, and as such will comment on the talk by Nadine Patt. To my knowledge, he is the first medical doctor to pursue a PhD in neurorehabilitation in India, and has also tremendous research experience in clinical neurorehabilitation, also especially in neuroimmunology, and it's a pleasure to have him here. As I said, it's also a pleasure to introduce our special guest, Professor Wayne Feng, who's the division chief for stroke and vascular neurology at the Department of Neurology at the Duke University in North Carolina. He's not only a WFNR member at large, but also the WFNR regional vice president for North America, and is also extremely active in research, but now will tell us about the mentorship program of the WFNR. So thank you very much for accepting the invitation, you all, and so the stage is yours, Wayne.
Sure. Thanks, Ila, for your very kind introduction. First, I really want to thanks to Professor Walker Humber for his vision and leadership and looks like we have a little frozen. Can you hear me okay?
Yes, I can hear you.
Okay, give me 1 second. I have a little bit of... Give me 1 second. All right, can you see the slides well?
Yes.
Okay, well, thanks, Eli, for your kind of introduction. First, I also want to and thanks Professor and Walker Humber for his vision, leadership, and trust in me. As he said, I been mentee before, now I'm a mentor, still the mentee. I'm very excited to work with you all and to launch the World Federation Neurorehabilitation Mentoring Program. Also want to thank Ela for your lot of work in this area, really get all the and a young investigator together, because this is critical, because I'm firmly believe the success of a professional society heavily depends on whether it can attract and retain young members or not. If a professional society cannot attract young members, I think that professional society has no futures. I'm sure you all know Jane Goodell, which is my hero, and as she said, it may sound so trite, but the young people are really the future. So the future is you, it's not me, and that's very important. We want to build a mentoring program, foster the growth of you all, so you can be leader of the future. So what is mentor and mentee? Why is this important? Why we need to actually promote such mentor and mentee relationship? Mentor and mentee relationship is a professional interpersonal relationship between a senior person who is acted as mentor and a protege, and aim to offer advice, guidance, and skills. And this relationship is completely based on no payment. Okay, it's not employment. It's all volunteer. It's professional relationship. The biggest rewarding from this is the growth of the mentee, and also the rewarding to the mentor. So they need to commit to each other, even there's no payment in place. They have to have a trust. They have to meet together, define some goals. The goal for the mentor, the goal for the mentee. Okay. They have different roles and different responsibilities, and they will work together and to achieve some results, some goals. They really just and come together. Okay. So here's one advice. If you're looking for a mentor, here's a few quality features you want to look at. You're looking for someone who can challenge you, not just say great job all the time. They actually want you challenge you a little bit, set up some goal for you. And this person is really invest in your success, your career. And this person typically is more senior than you. Okay. And they can provide some answer to some of the question. This could be a research question. This could be just a career question, or this could be a question during your grants writing or manuscript writing. Okay. Is this person somebody you want to be in 5 years or 10 years? Okay. As I said, this person can provide a constructive feedback, not just say great, great, great. Actually want to challenge you, provide some constructive feedback. And if you don't do good, they should be honest to give some feedback so you can improve. But they don't trash you. They are here to support you. They're here to respect you. I personally think a good mentor is a really good listener. They have to listen you need. Okay. They typically busy. But if they can be a good listener, they will be good. The other important feature of the members, they're typically senior. They're very busy. They have a lot of responsibility, but they have to be approachable. They have to be available. Okay. They're willing to sit down to talk things. Here are the mentors I list in my life, and they all help me during different stages of my training. And I think all those mentors, have a majority of those features of quality, and I benefit a lot from advice from them. And now I'm getting great here. I'm also in a position, and I probably can mentor some of the mentees. And here's 10 more things. Once you've identified a mentor, I would encourage the mentees to pay attention those 10 things. Number one, remember your mentor's a volunteer. Okay, there's no pay. You know, they are very busy, but they are willing to provide some advice for you. So please respect your mentor's time. You have to develop a trust. The first thing is you put your trust down first. Okay, and take a responsibility for your own learning. Okay, they can't do everything for you. They can help you, provide some advice, provide some direction, but you still need to do the real work. Okay, and have a realistic expectation. Okay, if you live in Germany, your mentor's in the US, you can't say let's fly every quarter and meet in Canada. Okay, that's unrealistic. Okay, and then or you say, well, here's a paper, please write the paper for me. That's an unrealistic expectation. Okay, when you meet with a mentor, I encourage you set up an agenda and say, here's 10 things I have, or here's 5 questions I have. I really like to get your advice. So send this a couple of days before so the mentor can be prepared. Okay, be open about your needs. It's okay to say, I need your help on A, B, and C. It's good to provide some feedback saying, hey, Professor Fan, you must be very busy, and this year, I think we missed one quarter meeting. I understand you're busy, but I have some needs. I really want to meet you, and in the next 3 weeks, can we set up the meeting? Okay. So be open about this. Recognize your mentor has limitations. Okay. They can do things, but they can't do everything. And be flexible. Be learning. It's okay. Maybe they are really busy, miss the meeting, but that's okay. Sometimes they may not meet your expectation all the time, but as long as you benefit, be flexible, willing to learn. And I think the last one kind of duplicated. Yeah. So those kind of things I really want a mentee to pay attention on this. And the most important, I think, is you take control. Okay, don't expect a mentor to do everything. You know your needs, and then you will get you what you need. If you don't know what you need, they're not gonna get what you need. Okay. Again, how to promote a successful mentor and mentee relationship. To get connected with all the tech knowledge, we can get connected, meet on Zoom. Despite all the COVID challenges, we probably cannot meet in person very often. Communicate, okay, by emails, okay. Try to find something, maybe work on together, get your input, maybe write a review paper with your mentor, and cultivate the relationship, okay. And circulate about the relationship, let people know, I have a great mentors and work really well. Talk about good things to celebrate, if you guys, if a mentee achieves something, get a travel award, notify the mentors, and give thanks to the mentors, or you get a paper publication with advice from the mentor. Give the credit to the mentors. Let's celebrate all those. Those are very important to promote a good relationship. Okay. World Federation of Neuro Rehabilitation is a professional society for neuro rehabilitation. Has a really good history to promote a mentor and a mentee relationship. I'm just fortunate to take the lead at this moment. We have a whole plans, and we have a research program seminars, and chaired by Professor Nam June Paik. You probably got emails, really all invite all the major research and talk about it and research. And it's great a seminar, sometimes talk about research methodology. Professor Thomas Platz from Germany and I have the neurorehabilitation teaching course. I believe will be offered during the World Congress. It's really give you comprehensive view about neurorehabilitation. So it's a really great introduction course. Eli's doing a great job and set up a significant interest group for the young group. So he can be your bridge. He can pass on information to the mentors, tell you need. So if you have some ideas, let him know. Any feedback, let him know. Okay. We have the mentor and mentee seminar, just like today. Every quarter, we can invite an expert and experts and a junior investigator. Let them present a project, and we're gonna give some feedback, maybe critique, to help you think about your project. Okay, we'll work on some mentor and mentee matching program, which I'm gonna show you the picture over here. We all work on it. I'm just showing the picture over here myself. Can you guys see it? It's a mentor profiles. It's just one page, shows a picture of the mentor, very few lines about the mentors, and then tell them the leadership role with World Federation of Neurorehabilitation, what kind of expertise they in. For me, my expertise really brain stimulation, stroke motor recovery, how to design a high quality clinical trial, how many mentees I'm willing to accept. I say 2. So we are sending a lot of emails to the senior mentors and who are willing to be a mentor through the World Federation Neurorehabilitation Leadership Group. Hopefully in the next 2 months, we'll have a group of mentors and we'll compile those files on the website, and you guys can take a look at it and then see, hey, Professor Pham and maybe Professor Cattorini is my top 2 candidates, but I'm not sure. They already take someone. And so here's my profile, and they help you kind of match a little bit and to define who's going to be your mentor. And then hopefully you got to kick off and meet and by Zoom. And then during the World Congress, you guys come together, meeting together, and talk about it more. Okay, so this really a whole and a plan for the World Federation of Neurorehabilitation, not to include the other ideas. We really want to point out all the resource on the website. Want to point out what kind of fellowship trainings offered by certain country. For example, Fogarty International Center, and in the U.S. regular offers some in training opportunities. Some are in the rehabilitation and topic. We'll provide all the information on the website so you guys can get all the informations, and we'll also provide all the major conference, which is a major conference offers young investigator award, travel scholarship. So you guys can apply all those things. So we really want to kind of provide a platform and for the junior investigators, so you guys can see what the Federation Neurorehabilitation serves a resource for you. With this, I'm just going to pause over here and to answer any questions about the mentoring program and from the World Federation Neurorehabilitation. We're going to do more of those in the next few months. So we'll promote those programs, and then we'll go from there.
Okay, thank you so much, Wayne, for your contribution and for your work, of course. As I said before, it's absolutely crucial for early career professionals to have, in my opinion, to have a very good mentor. As you pointed out, mentors, good mentors are relatively rare. Not all mentors fulfill all these 10 criteria. And it's all the more precious that we have, that we will have a variety of mentors to choose from. So thank you so much for your work on the mentorship program. Are there any questions from the audience on the mentorship program? If so, feel free to write in the chat or also in the question and the answer section. If not, I would have a question first. So Wayne, you told me that you will put up some profiles of potential members in the next 2 months. Is that correct?
Yes. Yeah.
And this can be accessed through the WFNR website.
Yes. Yeah.
Okay. Okay.
Yeah. Yeah.
Will you specifically highlight this somewhere on the WFNR website?
Still in the process of which exactly link, but at this moment we we have a templates ready, and we're gonna email and a group of senior investigator who are if, who are part of the members of the World Federation Neuro Rehabilitation, and we ask them to send us a mental profile, and then we hopefully to post on the website. And then you guys, and each of them, they will say how many they're willing to host, what kind of expertise they're willing to provide. And I said, well, post over there. And so junior investigator like you and Maria or someone who can look at it and say, hey, I really want to get some mentor like a Professor Homburg, and then send a request, and then we figure some matching and opportunities and get you connected, and then you guys kind of take off and then go from there.
Excellent, thank you so much. And of course, yeah, it's of huge importance. I've already been approached by several young members of the Young WFNR who asked me whether it would be possible to find a mentor. I see we have 2 questions in the question and answer section. We will have time for some short answers. So Justin Huber asks, remote mentorship has been great resource to him so far. Is there literature research available to guide young researchers that are developing this kind of mentorship?
Yeah, that's an excellent question, Justin. That's an excellent question. Justin actually sort of kind of my mentee. We actually are different institution. He's at University of Kentucky. I'm at Duke. I met him, and then we've been meet on quarter basis. They are, Justin, I will provide some literature resource you can actually and to look at it. What I would do is appoint some resource, send to Eli. Eli will distribute out, and then to really because I think a mentee really need to take the driving seats and to in charge of this mentor and mentee relationship. Yeah. Yeah. The second question, are we going to notify by email? The answer is yes, probably in the next 2 or 3 months. Yeah.
Well, we have a multiple step program, which is just starting now.
Yeah.
The first step will be to find the mentors. We will send that out to, let's say, people who are likely to be good mentors, so that we have a list of mentors available, and we will put that on the website. That will be stage 1 and stage 2.
Yeah.
3 will be that, and at the beginning, we will do that through Tracy's office in England, so that we find a mentor-mentee matching. Depending on the numbers, we don't know anything about the numbers yet, of course. We will eventually, sometime later, change to an automatic or let's say digital system for mentor-mentee matching. But at the beginning, we'll do it through our British office.
Thank you so
much. What you
much.
can do in addition is that we inform members of the young WFNR sick directly by personal email about the available mentors.
Mm-hmm. Thanks, Volker.
Thank you, Volker. So I suggest we move on to the first speaker. So it is my pleasure to introduce my colleague from Colombia, Dr. Maria Spear-Brunal, who has accepted my invitation to be the first speaker of this first Young WFNR quarterly research webinar. Dr. Speer-Brunel is a 24-year-old medical doctor from Colombia who has completed her studies in this year and has started to work as a research physician at the group Rehabilitation and Health of the University of Antioquia in Medellin, Colombia. And she is also a research physician at the University Hospital of Medellin in Colombia. Despite her young age, she has already been very active in research, a very prolific researcher, has also published multiple reviews about the response of the healthcare system, for instance, to the COVID-19 pandemic. Today, she's here to talk about the instruments of quality of life, functioning, depressive or anxious symptoms, and neurocognitive sequelae completed by a proxy, a topic which is of great importance. As we all know, most or a lot of neurological patients are not able anymore to complete surveys to reflect their subjective cognitive function, life quality. So it's of crucial importance that we evaluate and assess the evaluation by caregivers. I guess you have a pre-recorded talk, Maria. That's right. So I will kindly ask Christian to play the pre-recorded talk. And after the talk, we will have a short round of discussions.
Good afternoon, everyone. Thank you for this opportunity, mainly to Dr. Elia Fischer for the invitation. My name is Maria Alejandra Speer-Brunel, and I belong to the Health Rehabilitation Group at the University of Antioquia in Medellin, Colombia. Also, I am a member of the John World Federation of Neurorehabilitation, and today I am going to talk about the instruments of quality of life, functioning, depressive and anxious symptoms, and neurocognitive sequelae, complete by a proxy. Systematic review. So I will speak in order: first the introduction, then the methods, results, limitations, implications for practice, and conclusions. The evaluation of the health status of patients is essential to provide a reference measure that allows quantifying the variations over time related to the progression of the disease or to the clinical interventions that are carried out. Currently, the evaluation of the perceptions that patients have of their health is carried out with instruments called patient-reported outcomes, which complement the traditional measures of morbidity or mortality. These measures reflect how individuals feel and function in their daily life. Many of these instruments have been reported in the literature that assess general status, quality of life, functioning, depressive or anxious symptoms, or neurocognitive sequelae. Most of these instruments are complete in a self-report way. However, in some cases, for the evaluation of the health status of patients, it is not possible to obtain data directly from the patient because they have some disease or some comorbidities do not allow them to provide information. In this way, the proxy response have been described as a solution and are widely used to maximize survey response rates. For this reason, the objective of this study was to evaluate the concordance, correlation, and reliability of quality of life, functioning, depressive symptoms, anxiety, and cognitive impairment instruments that cannot be applied to the patient and can be completed by a proxy. But first, what is a proxy? A proxy is a person close to the patient and can be a health worker, a relative, a caregivers, or a person in shares of the patients. So proxies can be used when there are some difficulties in applying the scales to patients who have, for example, some disease or comorbidity, sequelae caused, for example, by a stroke or brain injury, cognitive impairment, or those who are critically ill. A systematic review of the literature was performed, which was registered in Prospero and reported according to the preferred reporting items for systematic review and meta-analysis statement. A systematic search was performed in these databases. The inclusion criteria in this review we include all studies that evaluate adult patients with any condition to whom any of the following scales have been applied. First, the short form 36 health survey questionnaire SF36 to evaluate the quality of life of patients. Then the Montreal Cognitive Assessment MOCA to evaluate neurocognitive status. World Health Organization Disability Assessment Schedule (WHODAS 2.0) and Disability Rating Scale (DRS) to evaluate functioning, and the State Trait Anxiety Inventory to evaluate anxious symptoms, and the Patient Health Questionnaire 9 (PHQ-9) to evaluate depressive symptoms. It was also a criterion that the scale had been filled out by both by the patient and by the proxy, and it was necessary that all studies present the score or statistical measures for the comparison. And the exclusion criteria, we exclude articles in which the instrument filled out by the patient is not the same as the one filled out by the proxy, as well as articles written in another language than Spanish or English. This is the study selection and the Prisma flow chart. After the identification of the records in database, we screened 271 articles. For the full text articles evaluation, we screened 55 articles. Of those, we include only 19 articles that were 12 articles about the instrument of SF36, 6 about WHODAS 2.0, and only 1 about PHQ-9. The data extraction was carried out by 2 different researchers, and the evaluation of the quality was carried out independently by 2 researchers with the tool developed by the Joanna Briggs Institute called Checklist for Systematic Reviews and Research Synthesis. So these are the results. This first table shows the included studies categorized by general and specific conditions. First, we have the health condition, the specific condition, the instrument evaluate in each article, and the number of articles. Clearly, the condition in which the most articles were found was the neurological condition with 10 articles, one about Huntington disease, another one about people with disabilities secondary to neurological problems, 2 about the stroke, another one about Alzheimer's disease, another one about dementia, one of multiple sclerosis, one of spinal cord injury, and the last one about brain trauma. Regarding to psychiatric conditions, there are 3: schizophrenia, bipolar disorder, and schizophrenia, and mental illness in general. Also, we found 3 articles related to older adults, 2 about cardiac conditions, one about intensive care unit patients, and another one about other conditions. In the second table, we have the intraclass correlation coefficients and the confidence interval of the SF36. Here we have the population, the number of patient and proxy, and these are the domains of the instrument SF36. This is important to know because these are the ICC. So the ICC less than 0.40 represents a poor level of agreement between the patients and the proxy. The ICC between the 0.41 to 0.70 represents a moderate level of agreement, and the ICC greater than 0.71 is an excellent level of agreement. In this way, we can see in general, in the neurological conditions, all domains score have moderate to excellent agreement. In most of the domain of neurological condition, the greatest agreement was the domain of physical functioning, and the patients with multiple sclerosis, that is here Solari. This study shows the highest patients and proxies agreement in all domains. In all domains. In psychiatric conditions, there is a greater variability. The more objective domains, such as physical functioning, bodily pain, and physical gel summary, represents the greater agreement between the patient and the proxy. And the cardiac conditions and older adults, once again, the objective domains such as physical function, bodily pain, and physical health summary represents the ones who have the greater agreement between patients and proxy. This third table represents the effect size with coin Z with the confidence interval of the SF36. Here we have 0 to 0.19 represent a minimal effect, which is a good concordance between the proxy and patients. 0.20 to 0.49 is a small effect. 0.50 to 0.79 is a medium effect, and a greater than 0.8 is a large effect, which means a poor concordance between proxies and patients. So, in all studies, the physical functioning domain showed a small or minimal effect here, minimal or a small effect size, which means a good agreement between the proxy and the patient. In the ELIS study, here we have the ELIS study with no specific conditions, which involved approximately 65,068 proxy reports. In all domains of this study, there was an excellent agreement between patient and proxy. Regarding another scale, like HUDAS 2.0, here we have the table 4 that present the effect size with coin Z between the patient and proxy. With HUDAS 2.0, we only found 6 articles, 4 about neurological conditions, spinal cord injury, chronic back pain. We have to put here because it's the same article. Another spinal cord injury, traumatic brain injury, and Huntington disease. And the psychiatric conditions are mental disorder and schizophrenia. So we have that in a general way, we can find that 5 studies of the 6 studies had a good agreement between the patients and the proxies, except in this study, in this population in a specific, chronic back pain, because they have a large effect greater than 0.8, which represents a poor agreement between patients and proxies. Regarding the other scale review, in this article we found only one article regarding PHQ-9 about patients with stroke. Here we have the mean of the instruments, score 6 of the patients and 7 of the proxies. And the effect size was 0.19, which is a good agreement. In general, the PHQ-9 has a good agreement between patients and proxies. And regarding these other scales, no results were found. This can be explained, for example, the DRS has the possibility of being applied by a proxy. The limitations of this study were these. The quality of the primary studies was not good. In most of the studies where the level of agreement was evaluated with the intraclass correlation coefficient, the confidence interval was not included, which is important to better define the precision of the results. Also, the methodological quality of the primary studies was not good. The limited number of the studies found and the evaluation of other instruments that evaluate the same outcomes, because as we know, to access the quality of life, functioning, among others, there are many scales and we only include 6 of these in this study. Implication for the practice, we have that alternative sources such as proxies to obtain information about the patient's health is a feasible solution to the lack of response and missing data attributable to limitations in the ability of patients to respond themselves. This allows clinical decision making, and the use of proxies facilitate research and data collection process, which would improve the development of early intervention strategies. And the conclusions, in general, the level of agreement between patients and proxies were good, mainly when evaluating the quality of life and functioning with the SF-36 and HUDAS 2.0 instruments respectively. The highest level of agreement was in the more objective and observable domains such as physical function and physical performance, and the lowest levels of agreement was in the less objective domains such as emotional, affective, and self-perceived states. In patients who cannot fill out the instruments, the use of a proxy could help avoid missing data. So this is all the presentation. Thank you very much. Um, Thank you for your attention and for the invitation. And if you have any questions, so go on.
All right. Thank you so much, Maria, for this very interesting talk, and congratulations on your research. A very, very nice job and extremely important work as well. I'd like to pass the word to the experts. So for instance, Katerina, do you have a question, or any other expert, any other member of the audience?
Any member of audience? No? I can have some question.
Mm-hmm.
Thank you, Maria, for your excellent work. I have two questions. Your study included the systematic review of the last 10 years, I think. And these patients were evaluated during hospital stay or after discharge at home. It is very important also to understand about the type of disability, for example, in patients with the traumatic brain injury or stroke. Why? The disability rating scale have not provided the results because it's very specific for traumatic brain injury. And I think that it is difficult to understand the agreement between patients and the proxy. This is my three first question. I I leave the floor to Maria for a reply.
Hi, Dr. Esa. Thank you for the question. So the first question is about that if the review include 10 years. So yes, the answer is yes. The review include the last 10 years of all these scales. We only include these 6 scales because here in Medellin, we are doing a cohort study about approximately 150 patients of traumatic brain injury. So we have this difficulty to in the project to collect in the collection of the data, and this is the reason of this systematic review. And the second question is about the state of, for example, some conditions like traumatic brain injury. In the limitations, I report that the primary of studies, the quality of the primary studies are not good, so they didn't report these important things about the disease, like traumatic brain injury. I think it is important, as you say. I think it could. I will put this limitation in the project. Thank you.
Thank you, Maria. Another question, if I have some space for another question. You noted that the study reported some difference about relative and peers and the caregivers, for example, because the perspective is different. Because relative are addressed to see the performance of patients in a best way in respect to caregiver that is not necessarily a relative. This is one of the difference among the proxy, I think. And another aspect concern the perception of the low quality of life for patients with the chronic back pain. Chronic back pain is not a condition closely related to neurological disease, but also for orthopedic patients. Then it is not surprising that most of work, most of study are addressed to find correlation between patient and relative about chronic back pain. What do you think about?
Okay, so although it was not our objective to evaluate the different proxies, the difference between the proxy, for example, health worker, relative, or families, we found that the best agreement, the best proxy, it was the spouse, the woman, and the health worker. And it was like surprising to us because the spouse, they explained that the spouse and the patients share a lot of time together. So this is like the best proxy.
Yeah. Thank you, Maria. I have no other question.
Thank you very much, Dr. Esa.
Okay, thank you so much. Dr. Abhishek Srivastava, you were raising your hands. Just maybe one very, very short question.
One very small question, Maria. Thank you for a nice talk. Do you think among all your diagnoses you've spoken about, the multiple sclerosis has the most varied picture with 4 different subtypes, people having cognitive, behavioral, as well as physical domain being affected, and it got maximum concordance between the proxy and the patient in the MS group? How can you explain that?
Really, we don't know. We don't know why the spinal cord injury and the multiple sclerosis have the best agreement between proxy and patients. We can explain because the objective domains such as physical functioning or bodily pain are observable to the proxy. So we can explain in this way that the observable domains are very like visible to the proxy. So there are a good concordance and correlation.
Okay, thank you so much. Thank you very much, Maria. So we will move on to our next speaker. It's my pleasure to introduce a good colleague of mine and my friend Nadine Pott, 28-year-old sports therapist from Switzerland. Nadine has completed her Master of Science in Health Sciences and Technology at the renowned Swiss Federal Institute of Technology in Zurich in 2018, in spring of 2018, has then worked as a sports therapist until 2020, when she joined the rehabilitation clinics in Valence, a very well-known clinic for neurorehabilitation in Switzerland, to do her PhD project there and to do her work as a sports therapist. Her talk will be entitled High Intensity Interval Training and Energy Management Education in Persons with Multiple Sclerosis, with the question whether there will be long-term behavior changes. Thank you so much for accepting the invitation, Nadine. We're very looking forward to your talk. Thanks.
So thank you, Elia, for the kind introduction. I start to share my screen. I hope you can see it now. I think it works. So thank you very much for the kind introduction. And I'm happy to present to you our research project with the title High Intensity Interval Training and Energy Management Education in Persons with MS, a long-term behavior change. So first, I will make a short introduction about the clinic in Valence, where I work. Then I will present to you the study with first results and then a short outlook. So, as Elia already said, I'm working at the rehabilitation center in Valence, which belongs to the Valence Clinic group, with several locations spread across the eastern part of Switzerland, with the Valence rehabilitation clinic here in Valence, with 150 beds and focus on neurological and musculoskeletal rehabilitation. So here you can see an overview of the locations of the clinics of the Valence group spread across the eastern part of Switzerland, and also an overview of rehabilitation centers in the German-speaking part of Switzerland. You can see that there is a high density of rehabilitation centers, and there is a high offer for rehabilitation. So now we come to the presentation of the study project. We have several ongoing research projects in Valence, and I will present you the study in which we combined high-intensity interval training with energy management education in persons with MS. Last year, a study protocol was published, and I will refer to it in the introduction and methodology section. So, MS is a chronic inflammatory autoimmune disease of the central nervous system and is often referred to as the disease of 1,000 faces because the symptoms are very different. And fatigue is one of the most common and troubling symptoms leading to an impaired health-related quality of life in 65% of persons with MS. And I think this picture beautifully illustrates the feeling of brain fog that persons with MS often use to describe their fatigue. And with the Tamina bridge leading to Valence symbolically as the way out of this vicious circle. A multidisciplinary rehabilitation approach is recommended for successful management of symptoms. However, strong evidence to date is available only for unimodal interventions. And besides medications, exercise and energy management programs have the best evidence. So regarding exercise, it is known that high-intensity interval training versus moderate continuous training is more effective in terms of reducing inflammatory markers and fatigue and improving cardiorespiratory fitness and cognition. And regarding energy management programs, we know that inpatient energy management education versus progressive muscle relaxation is more effective in terms of improving health-related quality of life and self-efficacy in using energy conservation strategies and in reducing fatigue. So the primary objective of this study was to evaluate the effects of the combination of the two different therapy approaches on health-related quality of life after 3 weeks rehabilitation and after returning home at 4 and 6 months follow-up in persons with MS. Secondary objectives were to evaluate the effects on fatigue and mood, self-efficacy and occupational performance, cardiorespiratory fitness and disease-related biomarkers, and physical activity and use of energy management strategies. So the hypothesis is that the combination of energy management education plus high-intensity interval training compared with the combination of progressive muscle relaxation plus moderate continuous training will be superior to improve health-related quality of life and other secondary outcome measures at 6 months follow-up. So then we come to the methods. Here you can see the participant flow chart. The design is a randomized controlled superiority trial design. And the persons with MS, they were recruited from the rehabilitation center in Valence. They were consecutively recruited. They were informed about the study on the day of entrance to the clinics when they started their inpatient rehabilitation, and they were screened for inclusion and exclusion criteria, and the inclusion criteria are adult age, a definitive diagnosis of MS, and EDSS score up to 6.5, which means that they are still able to walk at least 200 meters, a total fatigue score on the fatigue scale of motor and cognitive function over 43, and literacy in German. The exclusion criteria are cognitive impairment, depression, pregnant women, and stem cell treatment in the last 6 months, and the previous participation in this study. So the participants, the 106 participants, they were randomized either into the experimental or the control group, and they performed inpatient energy management education twice per week, and high intensity interval training 3 times per week in the experimental group during the 3 weeks rehabilitation as usual, and participants in the control group performed the progressive muscle relaxation twice and the moderate continuous training 3 times per week, also during this 3 weeks rehabilitation as usual. So here you can see the interventions of the experimental group. On the left side, the high intensity interval training. Here, high intensity interval training was done 3 times per week. I hope you can see the video. This is a participant during an interval, and one training session comprised of 5 intervals for 90 seconds at 95 to 100% of the peak heart frequency. And I really like that video because you can really see how she pushes herself to the limit, and also the coach next to her is pushing her to the limit. Now you can see she already is finished the interval, and you can really see how she is exhausted after this 90 seconds. And this is very important in this type of exercise. Then on the right-hand side, you can see the energy management education, which is a group-based therapy, and they learn energy conservation strategies in this therapy, and you can see that they are discussing with each other, they are interacting, and they share their knowledge, their strategies, and this group interaction is found to be very enriching by the participants. And in these sessions, they learn strategies to cope with their fatigue in everyday life. They learn energy conservation strategies. They learn how to set priorities, how to schedule their day, the break management, and how to schedule their week. And it may sound controversial to combine an energy management education where they learn how to conserve energy with a high intensive training where they have to push themselves to the limit. But to build up long-term fitness, this balance between exercise and recovery is crucial. And the energy management education helped them to plan and organize regular sequence of exercises into their daily or weekly routine. Here you can see the interventions of the control group. On the left-hand side, the moderate continuous training, which is done 3 times per week. They cycle for 24 minutes continuous at 65 to 70% of the peak heart frequency. And on the right-hand side, you see the progressive muscle relaxation, which is a group-based therapy twice per week. And there they learn muscle relaxation exercises combined with deep breathing. So we had 4 measurement time points at entry to the clinic, the baseline assessment, then at discharge from the clinic, the second measurement time point, then the third measurement time point, and the fourth are the follow-up measurement time points at 4 months from baseline and at 6 months from baseline. The patient-reported outcome measures were assessed at all 4 measurement time points. The primary endpoint is the health-related quality of life the physical and mental component summaries of the SF36, and the secondary endpoints are the fatigue, mood, self-efficacy, occupational performance, physical activity, and behavior changes in energy management. Additional secondary outcomes were measured at baseline and at discharge from the clinic, which are inflammatory markers from the blood and cardiorespiratory fitness measured with a cardiopulmonary exercise testing. For the statistical analysis, an intention to treat approach was chosen and a baseline adjusted linear mixed model applied. So we are at the results. We started the recruitment in July 2020 and the recruitment ended in October 2021. The follow-up was completed in May 2022. And you can see here the flow chart. Out of these 182 persons with MS who entered the rehabilitation center during the recruitment phase with an EDSS up to 6.5, 106 persons were randomized into one of the two groups, intervention groups. And you can see here at T1, so at discharge, 52 participants in the experimental group and 53 in the control group were post-tested. Then at 4 months follow-up, 50 participants in the experimental group and 50 participants in the control group returned the questionnaires. And at 6 months follow-up, 50 participants in the experimental group and 49 participants in the control group returned the questionnaire. So here you can see first results of the effects of the interventions on health-related quality of life and fatigue. You can see the score levels in red. In red, you can see the score levels of the control group, and in blue, the score levels of the experimental group. And top left, you can see the physical component summary score. And you can see that there was a significant main effect of time, and there was a significant increase from baseline to 3 weeks, and a significant increase from baseline to 4 months, and a significant decrease from 3 weeks to 6 months follow-up. Top right, you can see the mental component summary score of the SF36, the health-related quality of life. And you can see also here a significant main effect of time. And you can see there was a significant increase from baseline to 3 weeks, and a significant decrease from 3 weeks to 4 months follow-up, and 3 weeks to 6 months follow-up. Bottom left, you can see the total fatigue score. There was also a significant main effect of time. There was a significant decrease of the fatigue score from baseline to 3 weeks, and a significant increase from 3 weeks to 6 months follow-up. So to conclude, the mental and physical component summaries of the health-related quality of life significantly improved from entry to discharge from the clinic. The improvement in the physical component summary could be maintained until 4 months after baseline, and then declined back to baseline level. And the improvement in the mental component summary declined back to baseline level at 4 months after entry and remained at this level until 6 months after entry. The fatigue level was significantly decreased after the 3 weeks of interventions and increased to baseline at 4 and 6 months follow-up. And the effects are not dependent on the intervention group. So then we are already at the outlook. So these results are not yet published. So the next steps are to finish the statistical analysis, to discuss the results, and to write the manuscript and publish the results. So here are the references for interested persons. And then we are already at the end. So thank you very much for your interest and your attention.
Thank you very much, Nadine, for this very nice presentation as well. Extremely important and fascinating research also. Congratulations on your project and also on your results. I'd like to open the discussion. First, maybe are there any questions from the experts, specifically from Dr. Srivastava?
Thank you, Nadine, for a very nice study. You got with the fine memories of me visiting Welland some 10, 12 years back, and your study is really amazing. Fatigue is the most important factor, the invisible disability in MS. Your RCT design with fair large sample size, good follow-up duration, relevant tools, good Pedro score also. But I have a couple of questions. First, how did you calculate the intensity of the exercise regimen in the high intensity group? And do you think that intensity is enough to make a change in those patients?
So thank you very much for your question. The intensity is set according to the cardiopulmonary exercise testing, which is done at the beginning. So when they are recruited, then they have this cardiopulmonary exercise testing before they start the training. And then according to the peak value of the heart frequency, we set the goal for the training intensities. So this is done according to the cardiopulmonary exercise testing. And we for the second question, we have already done several studies here in Valence who compared high intensive training with moderate continuous training, and we know that both exercise modalities, they improve the cardiorespiratory fitness, but the high intensive training is more effective in improving this cardiorespiratory fitness, so the peak oxygen consumption. And what is also very interesting is this point with the inflammatory markers in the blood. So these disease-related biomarkers, and it was found that only the group which has done this high-intensive training has had improvements in these inflammatory biomarkers. So these inflammatory biomarkers were only reduced in the group which performed the high-intensive training, but not in the group who performed the moderate continuous training.
Thank you. One more simple question. Do you think are the two groups comparable? It was better to compare HIT versus MCS, but plus both groups having only the energy consumption techniques, because one group is doing training intensity along with energy conservation, other group is doing only more exercise with muscle relaxation techniques. They would be better compared to exercise regimens, but keeping the energy conservation techniques same in both the groups. Group 2 quite dissimilar to me. Are they comparable enough?
I didn't understand you quite well. I don't know why.
So there are two groups of exercise which are comparable, and there are two groups of energy conservation techniques. It would have been better if you have taken at least one thing similar in both the groups.
We combined these two therapy approaches because we wanted to investigate this multimodal therapy approach, because the unimodal interventions are already investigated, and we wanted to investigate this combination of exercise and education. And in one group they have this high intensity training, this high intensity interval training, plus the energy management education. This is this multimodal therapy approach. And then in the other group you have this moderate continuous training and the progressive muscle relaxation group. And this is also a combination of exercise and education. And we intentionally wanted to compare these two combinations because it is known that a multidisciplinary rehabilitation approach, this is recommended for the management of MS, and we intentionally wanted to compare these two combinations because it is already known a lot on the unimodal interventions, but these two interventions in combination have not yet been compared and investigated.
Okay, one small suggestion for your next result analysis, please also try to find out a subgroup analysis. How do different subtypes of MS behave with exercise regimens? You can do a subgroup analysis also for that in your results. Thank you. Thank you.
Yes, thank you very much for your input.
All right. Do we have some other questions from the audience or from Katerina?
Only one basic question, Dr. Pat. I would to know the physical therapy was performed, I think, by a physiotherapist, and emotional and relaxation therapy by psychologists or other professional figures.
Yes, you are right. The exercise interventions, they were provided by exercise scientists, and the progressive muscle relaxation was provided by also by physical therapists who have experience in this field, and the energy management education was provided by the occupational therapists who also have an education in this specific topic.
Not by psychologist.
Sorry?
Not by psychologist.
No, not by psychologists.
All right. Then I will seize the opportunity to just have one last questions before we head off. I know we're running late already. Sorry for that, but just one last question. Have you considered adding wrist-attached wearable devices, for instance, to measure daily activity, for instance, in your outcome measures, so to see whether there's an effect between the intervention group and the control group on daily physical activity, also in the long term?
Yes, actually, this is a very good input. This is always a very difficult question, as it is. You have always to do a lot. You have to instruct the participants with the watches and then you have to send this at home and they have to return it. And actually, it would have make the quality better. Then we would have had more data what they do at home. That's right. We decided to measure the physical activity with a questionnaire, with a customized and adapted version of the Godin Leisure Time Exercise Questionnaire. So we decided for this option.
Okay.
And yeah.
Excellent. Thank you so much.
Thank you.
So I will just have a quick word of goodbye. Nadine, can you quickly share your screen? So just stop screen sharing.
Actually,
It's stuck.
I'm not sure if I can do it.
Otherwise, I'll already begin. So thank you so much for all the speakers, all the experts for attending. It was very interesting to see your talks, to have your inputs. As people of the audience have already seen, there's a huge variety of research going on, and that's also what makes the field of neurorehabilitation beautiful. And people of the audience are kind of invited also to present their research as well in the upcoming research webinars. So as a little save the dates, there will be the next Young WFNR research webinar on November 2nd. The time is yet to be communicated, but there will be the next webinar then, where we will have 3 speakers. Some of you have already stated an interest in presenting the research, but always happy to have other suggestions, of course. So thank you very much, Maria. Thank you very much, Nadine. Also to Abhishek and Katerina, thank you and goodbye. Thanks. And to Christian, of course, for the technical support. Bye. Take care.
Thank you very much.
Bye.